Hello, everyone. I'm Dr. Janet Pope from Canada. I feel very privileged to be invited once again to your Pakistan 2023 rheumatology meeting. Obviously, I can't be there in person, but I hope you have a wonderful meeting. So I wanted to talk about some myths and some truths within rheumatoid arthritis. So an update on what we know and what we think we know, but maybe don't know about rheumatoid arthritis. And these are my disclosures. So we all know rheumatoid arthritis can have many looks. You can have lung disease with interstitial lung disease or rheumatoid nodules, subluxations, a lot of damage on X-ray, poor function. And we know that rheumatoid arthritis lung disease affects about 3 to 8% of people. It increases in age, and sometimes older disease duration. So I wanted to talk about rheumatoid arthritis, some assessments and insights, and to really almost in a way do a true and false game. And I want to challenge your assumptions in rheumatoid arthritis. So we all think about rheumatoid arthritis as a trigger. In some people, it's smoking. It can be infection, usually not COVID, but other infections maybe. We develop an ACPA, then our immune system goes askew with another thing, another hit, another immune stimulation, and eventually you might get rheumatoid arthritis. And we tend to think it starts in the lung, goes to the bone marrow, and then the synovium. So that's an assumption that we have. And we know that the cytokines vary in rheumatoid arthritis from TNF alpha, IL-6 inhibition, IL-1, IL-17/23, not as important in RA as, say, psoriatic arthritis, interferon type 1, etc. Many different cytokines and mediators. And they might peak at different parts in the illness of rheumatoid arthritis, from preclinical to early to chronic. So we're going to play a bit of a true and false game, and I'll say things and then pause, and then I will give you the answer. So true or false? So the incidence of RA is decreasing over time. The age of onset of RA patients is increasing, even in Pakistan. Extra-articular manifestations are decreasing, such as nodules, corneal melts, neck subluxation. There is a window of opportunity for RA treatment. RA interstitial lung disease mortality has been decreasing, and RA is a major risk factor for poor outcomes with COVID. So when we look at these, the incidence is actually increasing, especially in older people. The age of onset is increasing. Extra-articular manifestations are decreasing. There is a window of opportunity, but it's never too late to treat. But in the window of opportunity, more people will go into remission, less epitope spreading. RA-ILD mortality is actually going up, whereas overall RA mortality is going down. And RA is not a major risk factor for poor outcomes with COVID. Older age and other comorbidities such as heart disease, lung disease, and diabetes would be higher risks. So these are Canadian data, so you probably have to shift your curve in Pakistan over about a decade and a half, but knowing that rheumatoid arthritis is increasing in the elderly, almost doubling over time in people over the age of 80. So our mean age of onset in Canada is 55 years old. Your mean age of onset is probably in the 40s, low 40s, because you have a younger population. We also know that older patients have more comorbidities, so they don't always go into remission because comorbidities decrease remission and might also be under treatment. But here's the elderly over the age of 70s. In this study, 13% had cancer at the onset of their RA, ever cancer. 14% already had heart disease. 14% had diabetes, and 10% already had bronchitis or emphysema. So it's harder to go in remission when there's more comorbidities. So there's lots we know and some things we don't know. So what we do know, I mentioned already, a window of opportunity exists, that there's more epitope or antibody spreading over time, so more difficult to treat a target that is broader than a sort of almost like a monoclonal antibody target at the beginning of an ACPA that's very specific. It goes more widespread over time. We know the safety of treatment exceeds the safety of no treatment for all our treatments in rheumatoid arthritis. We know that the outcome measurements are sensitive to change, but they don't necessarily reflect disease activity. And we know many predictors of poor response. But what we don't know is a person in front of me who will progress over time. I don't know why RA patients flare. I don't know why they become treatment resistant over time. I don't know what order to use advanced therapies. And I really don't know how to treat some of the extra-articular manifestations. Interstitial lung disease, after CST MARDs, maybe I would use something like rituximab or abatacept or tocilizumab. Rheumatoid nodules, many of the treatments don't seem to work well. Other extra-articular fatigue, Sjogren's, very difficult to know what to treat them with. So there's one myth in early rheumatoid arthritis that we can prevent RA. So we are not ready to screen asymptomatic population. But what about patients with arthralgias who are ACPA positive? We know as high as 1 in 3 over the next 2 or 3 years will develop RA, meaning 2 out of 3 won't. And in some studies, only 1 in 6 will develop RA. We're not ready to treat these people yet. So vaccination of ACPA positive healthy people is underway in studies, obviously not ready for prime time. Smoking cessation, healthy BMI, healthy diet, Mediterranean type diet, maybe adding vitamin D of 1,000 or 2,000 units a day. Maybe all these things might help decrease the chance of RA, but certainly don't prevent it. We also know that the ACPA and rheumatoid factor precede rheumatoid arthritis. You've seen this kind of graph many times, I think. So they can start 14 years prior and then go up over time. But what we don't concentrate on this graph is when you get rheumatoid arthritis, you can see at time of diagnosis, which is 0, only about 40% or 40-some% of patients with ACPA positive or RF positive patients will develop RA. So there's half our people will develop RA without this predestined autoimmune change. Another myth, therefore, is that RA development should have ACPA years before. So we know that that's not always true by that graph. And in fact, these are data from our early rheumatoid arthritis cohort in Canada called the CATCH cohort. And you can see seropositive for RF or ACPA at the time of diagnosis, which was less than 1 year of first swollen joints that were fixed, was only in the high 60s. RF positive, about 60%, ACPA positive, about 64%. So the other side of that is 40% or 36% do not have autoantibodies that we would routinely measure at the time of their diagnosis. So then thinking next, what about lifestyle factors that might increase the risk of RA? So this is a multiple guess to choose your knowledge. Which factors are not associated with an increased risk of RA? Smoking, normal BMI, inhalation of silica dust, positive family history of RA. So some of these factors we can control and some we can't. So I think most of you will know that normal BMI is not associated with RA risk. High BMI and very low BMI, but in particular, high BMI is associated. So in the Nurses' Health Study, this is looking at lifestyle factors. And in the Nurses' Health Study, they're looking at lifestyle factors in 120,000 women, of whom, as you would suspect, a certain percent get rheumatoid arthritis, so most don't. So if we look at the health style related factors, the more things you have that would be bad factors, or conversely in this graph, the protective factors, the more likely you won't get rheumatoid arthritis. So if we said your risk of getting rheumatoid arthritis is 1, if you have protective factors, it'll be less than that. So never being a smoker, normal BMI, drinking alcohol, interestingly, in moderation, exercising regularly and having the most healthy diet, all these people have the lowest chance of having rheumatoid arthritis. And it's like a dose response. 1 protective factor is less protective than 4 protective factors, as a for instance. Okay. So I've talked a bit about smoking. So is it a myth that smoking is a major risk factor for rheumatoid arthritis? I'm not trying to tell your patients to stop smoking. They all should stop smoking, but I just want to explore this statement. So here is if you have smoking versus non-smoking and the shared epitope, HLA-DR4 0101. So the shared epitope is this specific marker. It's not all HLA-DR4. It's DR4 0101 or 104. That's the shared epitope. And you can see if you're a non-smoker, the orange, this is your risk of getting rheumatoid arthritis on a double epitope versus single versus none. But you can see it's far higher if you're a smoker with the double shared epitope. But this is if you don't smoke and you have the shared epitope. It seems like the shared epitope no longer is a risk factor. The double shared epitope is the same in smokers and non-smokers if you are antibody negative. Smoking increases the chance of rheumatoid arthritis, but only in a very specific genetic at-risk population. So it's not sufficient to be a smoker alone, but we should still tell our patients to stop smoking. What about BMI? So if you have a high BMI and you're ACPA positive, that's that highest graph of the 23 odds or 22.72 times higher chance of getting rheumatoid arthritis. But if you're ACPA negative, your odds with a high BMI are very low, just a little bit above 1. And if you're ACPA negative and normal BMI, it doesn't seem to make a difference. Or if you're high BMI or moderately high BMI and ACPA negative, it doesn't seem to make a difference. So in fact, again, there's an interaction term between high BMI and ACPA positive, just like ACPA positive and shared epitope. So not all risks are equally distributed, just to know. A myth. We can get most RA patients into sustained remission. Now that would be wonderful. That is our target when we're treating to a target, but it is a myth. I think that myth is true. So these are data from our early rheumatoid arthritis Canadian catch cohort by year of entry into the cohort, and then looking over the next many months, so looking at 12 months. And you can see that we go up over time and getting more people into remission. And we have in a tight remission, such as DAS remission, over 70% of our patients are in remission in the newer years of the cohort compared to earlier years, which were 2007 to about 2012. We were going better every year, but we're still doing better. But now we're kind of hitting a wall, and that's getting them into remission. The most treatment positive or patients that come to clinic are willing to be observed. So they sign a consent, they come back for their follow-ups, and they're treatment responsive often because they're early in disease, usually about 3 months of first fixed swollen joints, so very early disease. So we can get lots of people into remission, but what about sustained remission? So these are data, again, from our early rheumatoid arthritis study, the CATCH cohort, and we're looking at the inner green circle first. So at the inner green circle, we could get half the patients into remission with a CDI remission. So the simple disease activity index, which is the tender and swollen joint count, MD global, patient global, and CRP. So that is the tightest remission that we can get. It's other than, I guess, Boolean remission. And we get half our patients there. But what happens a year later or 2 years later? So you can see a year later, green is sustained remission. That's the next circle, that about half the patients who made it to remission are no longer in remission at 1 to 2 years. Some are in near remission or low disease activity, the yellow, but some are in high disease activity or moderate disease activity, which is the red. So we get half the patients into a tight remission of over 3,000 early RA patients by 1 year, but half of that half are out of remission over the next 2 years. So we're doing well, but we're not doing good enough. And then more than half of the patients in a prevalent cohort never reach remission. This is saying DAS remission, about 42%. These are thousands of patients studied and looking over time, cross-sectionally who's in remission or how can you get remission in the next year. And the SDI remission in established disease, we found it to be almost 50%. Here it's only 21%. It is very difficult to get prevalent patients, long-standing patients into sustained remission. Not impossible, but very difficult. And then we also know, if you look at all the targets that we have, these are some of many: methotrexate naive, methotrexate inadequate responders, TNF inadequate responders, looking at all these various drugs. And it doesn't really matter what drugs we're looking at, but you can see in all of them, most of the patients do not get a high response like an ACR 70. At most about 40% and a lot of times it's 30% or 20%. We do not do well on a change in response to get most people into remission. And I know you're all aware of that as well. Also, once you're in remission, drug retention is not very good over time. So this is just one example of looking at drug retention in the darkest blue color of tofacitinib monotherapy or combo therapy, then looking at other mechanism of action such as the non-TNF biologics, and then looking at the TNF biologics, and especially monotherapy of TNF biologics, the retention is it's less than half the people by 2.5 years are still on drug. So when we get them into remission or a low disease score, many don't stay there. Okay, what's another myth? That treatment selection and order of treatment in RA is rational. It's rational sometimes with respect to payers. We should use less expensive drugs first if all things are equal, but it is irrational. And this is a way of looking. We have our EULAR and your local guidelines, ACR guidelines that say start with methotrexate, EULAR guidelines, methotrexate plus glucocorticoids, get the glucocorticoids off when you can, and then add other drugs over time and try to maintain methotrexate. But these are data looking for personalized medicine. So I borrowed this slide from a study, and what it's showing is that there are different groups of patients with different pathophysiology who are all rheumatoid arthritis. And in this study, there's groups with high lymphocytes or lymphocytic lymph nodes kind of picture, other lymphocytes, and then some that are very fibrotic. And the fibrotic group actually doesn't respond well to our current treatments. So we do need personalized medicine, and we're not there yet, but that will help us to give maybe a rational order and the right drug and the right person at the right time. We are not ready for that yet. So another myth that I've alluded to is that the EULAR and ACR guidelines of monotherapy with methotrexate as initial therapy makes sense. Well, I'm here to tell you, even though I'm published on guidelines, the Canadian guidelines, the Canadian ones we're updating, and I'm also on the EULAR RA guidelines, I can tell you that I disagree with this statement. Why? Because 70% of the time we will fail. So in every study, randomized controlled trial in early rheumatoid arthritis that compares methotrexate monotherapy compared to combination therapy, 2/3 or 70% on monotherapy do not achieve remission on methotrexate monotherapy, whereas 2/3 do achieve remission if they're on combination therapy, whether it's double or triple conventional synthetic DMARDs, such as leflunomide, or triple therapy, methotrexate, hydroxychloroquine, and sulfasalazine, whether it's an advanced therapy, such as a TNF, two drugs are always better than one. Some might not be cost efficient, but combination conventional synthetic DMARDs are in particular cost efficient. So guidelines have us fail 70% of the time, just to be aware. So true or false? Folate supplementation improves tolerability of methotrexate. So you're going to think, is this true or false? And folate supplementation should be co-prescribed with methotrexate in patients with rheumatoid arthritis. So the second is a guideline for most jurisdictions that you should give folic acid supplementation. And in some of your patients who are low body weight or cachectic, folic acid supplementation makes sense. But folic acid supplementation in Pakistan is more cost for your patient. And is it always necessary? The right answer is it's true or it's false. It depends on how you read the data. So this is a systematic review, a Cochrane review from back in 2013 by multiple people from Canada and elsewhere. And what it's looking at is the randomized controlled trials of folic supplementation, folic acid, folinic acid, et cetera. Folinic acid is very expensive, by the way. And number one, it did not change nausea. Number two, it did not help oral ulcers. What it did seem to help a little bit was liver enzyme abnormalities and a little bit of GI side effects, but not nausea, not central side effects. And what it seemed to do in some of the studies was maintain better retention on methotrexate. So if you go, okay, so we should use folic acid supplementation in everyone, then you're going to say, see, it's a positive systematic review. If I'm going to say we don't need it in everyone, if you eat a healthy diet, you probably with green fruits or vegetables, you probably get enough folic acid. And in Canada and many other countries, folic acid is ubiquitous because we don't want moms to be folate deficient and have more neural tube defect babies. So in Canada, folic acid is in all cereal. It's in multiple drinks as a supplementation, not just a green kind of juice sort of thing. So in Canada, folic acid supplementation is probably for most people just something that they're peeing out, a waste of time and money. But our guidelines do suggest we should use it. Okay, so true or false, methotrexate is associated with more chronic interstitial lung disease and rheumatoid arthritis. So methotrexate can give acute pneumonitis, but methotrexate is not responsible for a UIP, usual interstitial pneumonitis pattern. It's an acute pneumonitis, often with the eosinophils, looks like acute pneumonia. So many studies, this is one of many, this is from back in EULAR 2020, but there are many studies now showing that methotrexate is protective against getting ILD. If you have interstitial lung disease on methotrexate, you can say you failed that, but it decreases the chance. Why? Methotrexate decreases disease activity. Disease activity is related to interstitial lung disease. And methotrexate is immune suppressive and can help the lungs, so it can be protective. So it's protective by reducing disease activity and also trying to not have the problem start or to treat the problem at the bases of your lungs where interstitial lung disease can occur. However, once you have ILD, methotrexate might be insufficient treatment if you've already failed it and gotten ILD while on methotrexate. Okay, true or false? It is better to hold methotrexate before scheduled hip or knee replacement surgery. Many of the guidelines say hold 1 week before, 1 week after. And in general, the right answer is true or false. So there are randomized controlled trials, 2 of them, that say holding methotrexate before and after joint replacements actually gives more flare, more wound dehiscence. And if you have flare, you're on prednisone, which can increase the risk of infection. So holding methotrexate for a long time before or after scheduled joint replacements is actually not the right thing to do. However, if it's held for 1 week pre-op, 1 week post-op, sometimes that allows the orthopedic surgeon to be more comfortable and you're worried about wound dehiscence, wound infection. But the data suggests not holding methotrexate is better than holding it actually for a long time. 2 randomized controlled trials. This is different though, looking at holding advanced therapies before scheduled joint replacements. Most studies suggest holding again a half-life before and a half-life after. So a dosing interval would make less joint infections, such as TNF inhibitors, JAK inhibitors, abatacept, IL-6 inhibitors, not for rituximab, because rituximab, we can't hold it an entire dosing interval. So rituximab getting the joint replacement a bit before you would be due for your next rituximab. So at the end of a 6-month cycle, so to speak. This study, however, says, this is an older one, says that holding TNF inhibitor versus not holding made no difference. And in fact, might have been protective in the younger age group, higher risk in the older age group, but in general made no difference. But most guidelines would suggest holding 1 dose pre-op, 1 dose post-op of TNF inhibitors. If it's a long dosing schedule, such as infliximab or golimumab, then you wouldn't hold as long, or you have a higher chance for people to flare. Okay, true or false? Chronic prednisone 10 milligrams a day is a higher risk of herpes zoster than a chronic JAK inhibitor in RA. So we always talk about JAK inhibitors increasing the chance of zoster varicella reactivation, but what are the real data? So these are data from the German RA rabbit registry, and looking at about a 12-year pattern of 12,000 RA patients, of whom 452 developed herpes zoster. And you can see the risk for herpes zoster was higher on the first graph there, higher with a JAK inhibitor than conventional synthetic DMARD or other advanced therapies. But if you look at the risk factors in the table I'm showing you, if you're on glucocorticoids greater than 10 milligrams, and I'm going to say, to be devil's advocate, greater than or equal to 10 milligrams, that is a high risk with a wide confidence interval. So is herpes zoster higher in JAK inhibitors? Yes. Is the risk, though, to our patients higher on glucocorticoids or higher on a JAK inhibitor? It depends. If you start a JAK inhibitor and you can get the glucocorticoids down to 0, you might have an equal risk, a higher risk, or even a lower risk than if they were on glucocorticoids with higher disease activity. So the real answer is it's a myth or it's true, because it depends on the patient, what they've had in past, and the dose of the glucocorticoids. Okay, true or false? Your function of as measured by your health assessment questionnaire disability index, or what we call HAC, of 0 to 3, your function at 1 year in rheumatoid arthritis is predictive of future mortality. We know high HAC in prevalent long-standing patients is related to higher morbidity and even higher mortality, higher hospitalizations. Well, what about an early rheumatoid arthritis, where our average age of patients is only 55 and your average age of patients is probably early 40s? So we did a study, and this looks a little bit busy, but basically your HAC at 1 year is related to the reversible part of your HAC and the fixed problems, like maybe having erosive osteoarthritis or frozen shoulders, other things unrelated to your rheumatoid arthritis. And we found the highest predictor of mortality was not baseline disease activity, was not baseline HAC, was not 1 year disease activity. It was your health assessment questionnaire 1 year into treatment of your disease was strongly predictive of future mortality, about a 1.5 times predictive, or as low as about a 1.25 or 25% increase prediction in mortality. So we want to try to not have damage. We want to improve whatever function we can in patients. Kind of makes sense. First time it's been shown in a large cohort of early rheumatoid arthritis patients, 1,700 patients. True or false? Elderly people with RA have more functional impairment than the age and sex matched population. Again, you might think, well, that's true, or you might think it's false, depending on if they're really old. It probably doesn't make a difference because you have mechanical back pain, erosive osteoarthritis, neurological problems. So it's true and it's false. So this is a graph over time of the past 20 years, functional disability in patients with rheumatoid arthritis. The first thing to note is that we haven't done too much better on functional impairment over time in our longstanding rheumatoid arthritis patients. But the next thing to note is the blue dots are non-RA over a 20-year period from 2000 to 2020. of non-RA, age and sex matched, just general population, and the red is the RA patients. So we haven't done any better, by the way, looking at functional disability over the last 20 years, unfortunately. However, when you get to the very old, the 85-year-olds and up, if you have rheumatoid arthritis, your functional impairment is about just as bad as the general population. If you look at a 60-year-old, your functional impairment is worse if you have RA, and a 70-year-old, it's worse. Once you get into the very elderly, so many other things drive functional impairment that our RA patients have similarly poor function as age and sex matched general population. So the answer is true or false, a myth or a truth, depending on how you look at the data. Okay, so a myth is a swollen joint is a swollen joint. We count them equally, whether I have one wrist, one MCP, or one knee, or one shoulder, that all of those would be one swollen joint. But we know the surface area of a shoulder or a knee is far more than a second MCP or even than a wrist. So it's kind of crazy to me that we count a swollen joint count and we count joints equally. They should kind of be weighted. And there was an old scale that rated the Ritchie Articular Index, weighted the size of the joint and also the degree of swelling or inflammation. So in our minds, a patient with 4 swollen joints, that's 2 MCPs, 2 PIPs on their dominant hand, is very different than 2 knees, 2 big swollen elbows, we'll say, and maybe they also have ankles swollen, which aren't counted on a swollen joint count of 28. So obviously 2 shoulders and also maybe having ankles is far different than 2 MCPs on the degree of poor function, the degree of inflammation that's going on. What about cardiovascular risk? Are we overestimating it when we sort of add a 1.5 or a 2 times in our calculator? Cardiovascular risk in rheumatoid arthritis is a real thing in Pakistan. You do have premature atherosclerosis, of course, more in men, more in smokers than in women. So it's a real thing. But the gap between the general population rate of cardiovascular disease and the higher rate in RA patients, that gap is closing over time. And we do have cohorts in the world publishing that we are overestimating the cardiovascular risk, such as in Sweden and other parts in Scandinavia that have published the mortality gap, not the getting an MI, but the mortality gap in rheumatoid arthritis, those with heart disease that have had a cardiovascular event. In Scandinavia, the mortality is the same as the age and sex matched population who have a cardiovascular event. So are we overestimating cardiovascular risk, underestimating, or just right? I think it depends on the patient you're looking at, the country you're from, and the other traditional risk factors. Because traditional risk factors, positive family history of early onset coronary events, high cholesterol, smoking, diabetes, high blood pressure, all those things are higher risk than uncontrolled rheumatoid arthritis. But rheumatoid arthritis adds to that risk. But the traditional risk factors are more important for those who will get a coronary artery disease event. So I think there are many beliefs in rheumatoid arthritis that need to be challenged. I think we need to learn from oncologists to profile treatment. Will this person be drug resistant? Would this be the best first line treatment? And also, most oncologists treat with 2 or 3 or 4 drugs at the beginning of a cancer. They don't give lymphoma when they have CHOP-R, which is 5 drugs. They don't give 1 drug in that kind of lymphoma. They give 5 drugs to try to put people in remission. However, I think we've come a long way. There is residual pain and fatigue and unmet need in rheumatoid arthritis. And that's sometimes why our disease activity scores look high when we think the patient's in remission. There is indeed secondary loss of response to treatment, and we don't know who will get it or when. And I believe still in 2023, there is a lack of rational choice for the order of treatment in our patients. And I don't believe that methotrexate monotherapy is the best treatment approach in someone with active rheumatoid arthritis. But I am an outlier in that. I believe combination conventional synthetic DMARDs would be more cost efficient.
EULAR believes that methotrexate plus glucocorticoids would be better than methotrexate alone. The ACR recommends methotrexate alone. So we all do different recommendations and we still fail to get most of our patients in sustained remission. Even them in the window of opportunity, it's very difficult. Well, so with that, I'd like to stop and I hope you will have a wonderful and exciting meeting. Thank you.